Hi guys, this is John Adamson, the Rehab Documentation Guru, and I just did a live stream upload of a video which turned out really terribly for quality. So I'm doing a new one, and what I'm going to be doing this video about is a current denial trend. And according to the title, which you will see, it's on activity tolerance. And if you've been to my course, Documentation Bootcamp, you've heard me talk about activity tolerance and some of the problems associated with it. That's not really what's going on with the current denial trend, though. I'll tell you what's going on. So anybody that's in inpatient Part A settings, the way you get reimbursed, at least for right now, is how many minutes of therapy services you provide is going to be correlated to how much you get paid. The more minutes of therapy a patient needs per day, the more you get paid. And so we have a rug set up related to that. What's happening right now is this. We, of course, in post-acute care get a lot of very sick patients. These patients end up coming to us with low activity tolerance, which, as you've probably heard me say, means absolutely nothing. So what's happening is therapists are rating the patient according to sitting or standing activity tolerance, where they might either give a range like 0 to 15 minutes, or they might say a specific number like 10 minutes of activity tolerance. And then what the Medicare auditor will say is, well, if they can only tolerate 10 minutes of activity, why are you giving them 50, 60, 70 minutes of therapy per day? That doesn't make any sense. You're overtaxing them. So this is a current denial trend that's going on right now. So how can you combat that? Well, first of all, please stop documenting activity tolerance by itself, because it does mean nothing. Secondly, look at all of the functional things on your eval that you are going to be addressing. So for PT, you might have a number of activities that you're doing that will require some kind of tolerance, such as you might be looking at the three main functional categories that we usually look in inpatient rehabilitation: bed mobility, transfers, and ambulation. And then I would take each of those activities and take a before, during, and after cardiopulmonary measure, such as heart rate, blood pressure, pulse oximetry, perceived exertion, respiratory rate, things like that. If you find out that one of those parameters is not good, in other words, the patient has an abnormal response, just document those objective numbers, and that is the activity tolerance. You don't have to say activity tolerance, because what will happen is you will take a patient who is not demonstrating tolerance of that activity because of an abnormal parameter of a cardiopulmonary measure, and your goal will be to get them to do the activity, the same activity, with an appropriate cardiopulmonary response. And just leave it at that. That will eliminate what we're seeing as a current denial trend, where Medicare is latching on to these minutes of tolerance, or like graded activity tolerance, or things like that, and saying, look, they don't have enough minutes of tolerance to tolerate all your minutes of therapy. So keep it just simple per thing, per functional deficit area you're working on, and that's all three disciplines. And just focus on that. Provide objective numbers, and I mean cardiopulmonary primarily, which is going to be our main activity tolerance limiter. Or it could be something like pain, where pain is causing them to not tolerate the activity. And so we just record the pain with and without the activity. And our goal is to get them to do the activity with less pain so they can complete the activity. That's what I would focus on. And that way, that'll eliminate completely this denial trend, which I can probably pretty much guarantee will last all the way till October, when we finally get into the new payment system. But for now, we got to deal with minutes of therapy, and we have to justify minutes of therapy, and saying so many minutes of activity tolerance exists is one way that you will not get paid. And my goal, as always, is to make sure you get paid for what you do. So thanks for watching. Sorry if you caught the first video with its terrible, terrible quality. And if you like this video and other ones that I've done, please like and subscribe. Please recommend them to your friends. Also, just got it on Twitter, and I'll be posting these to Twitter, hopefully on a regular basis. I've never used Twitter before. I don't really like it, except I'll use it for this. But my Twitter account is Rehab Documentation Guru, and as opposed to my YouTube channel, which is The Rehab Documentation Guru. Anyway, thanks so much. Have a great day, and God bless.